Childhood experiences have a tremendous impact on the health well into adulthood and provide the building blocks for learning, behaviors, and health. Adverse childhood experiences are defined as a stressful or traumatic event that occurs in childhood, like physical, sexual, or emotional abuse, as well as household dysfunction, and you can see here what those are. And then studies show that exposure to ACEs in childhood is linked to a number of poor physical and mental health outcomes into adulthood, such as chronic diseases. Yet the relationship between ACEs and chronic conditions, specifically chronic pain, remains poorly understood in pediatric populations and in adult populations as well. But for this assignment, my focus question is from our scoping review, and it's what is known from the existing literature about the relationship between adverse childhood experiences and chronic pain during childhood and adolescence. So justifying using a cross-disciplinary approach. So the relationship between ACEs and chronic conditions like pediatric chronic pain are beyond the ability of any single discipline to explore. A review of the literature in psychology, biology, public health, and medicine show that these disciplines are not only the most relevant to the problem, but have analyzed the problem separately in their own disciplinary silos. So each discipline has produced its own theories or frameworks about how ACEs are related to chronic conditions like chronic pain. Yet none of these explanations comprehensively address the problem, and in fact can lead to incomplete views of the relationship. So disciplinary insights, this is from Repco. I just recreated the image. So the disciplines that I looked at were, as I mentioned, biology, psychology, public health, and medicine. What is the perspective of each discipline on the problem? So biology is really analyzing the biological process between ACEs and chronic pain. And then psychology is looking at the psychological impact. And then public health is analyzing the health determinants of chronic pain in a pediatric population exposed to ACEs and what the impact is on the quality of life. And then medicine is analyzing pediatric chronic pain and ACEs through establishing diagnoses, prognosis, and treatment modalities to maintain and or restore health. And it's going to be done in a systematic evidence-based way. And then what are the assumptions of each of the disciplines? Just really quickly, I'm not going to read that all, but biology is taking a deductive approach to looking at the research question. Psychology is assuming data is obtained through a systematic empiricism approach, allowing researchers to draw more confident conclusions than they can draw from just causal observations. Public health is assuming that prolonging life and improving quality of life can be done through organized efforts, like at a population level, and informed choices of society, organizations, communities, and individuals. And then medicine, again, is assuming that health can be maintained and restored by the prevention and treatment of illness and disease in a systematic evidence-based way, as I mentioned. What's so important to note here is that a reductionist approach will not apply successfully to this problem. It's very difficult to break down the relationship between adverse childhood experiences and chronic pain into parts and not have them relate to one another. So my literature search. I looked at the following databases. So PsycInfo, which is obviously psychology and related disciplines to psychology. PubMed, which is looking at life and health sciences, and then Scopus, which is more an interdisciplinary database. So articles were eligible for inclusion if they looked at child and adolescence and were written in English and reported on adverse childhood experiences and chronic pain. So the initial search identified 207 articles, of which 32 were removed, and then 175 articles were screened, title and abstract, and then 70 articles were identified for full text review if I was doing a true scoping review, but obviously for the assignment of the scoping review, we only had to do 16 articles. So those 16 articles, I made sure that they had various disciplines were represented, so that's what was used for this assignment. Challenges with an unfamiliar disciplinary perspective. So the challenges I encountered were really in the biological literature and statistical analysis approaches that were very unfamiliar with me. The modeling was very intense and I have not encountered that before and I generally stay away from that. But an example is articles focusing on childhood adversity associated with the hypersensitivity measured by area of secondary allodynia and temporal summation of second pain, TSSP. The measurement of TSSP I'd never heard of before. It's definitely in the biology space. Another challenge was that the public health literature is sparse. And I think this is just because this topic is very new. And there's not a lot of data that's out there. And then the measurements that are conducted at a population level don't really, they're addressing adverse childhood experiences and may not address chronic pain. And then there's also conflicts over the epistemic values, particularly among the biology literature, since it's more an eidetic approach versus an imic approach where you may see in psychology. So for the next steps for the literature review, we're really refining the search strategy based off of the World Health Organization and United Nations definition of adolescents, youth, and young people. And the reason why I did that is because in our pediatric chronic pain clinic, we actually follow, we allow children or young adults to stay until they're 24. And we actually include them in our statistical analysis just because the onset of their chronic pain was in childhood. And then reevaluate the exclusion of articles past 10 years old. It's really thinking about, will adding these articles introduce error into the study? What's important here, and the reason why I'm thinking about doing this is because in the literature, a lot of articles from subsequent years keep repeating these same seminal articles. And it's also because these older articles looked at adverse childhood experiences or pediatric chronic pain in a specific clinical population. And no one has done that since. So thinking about, like, should I go ahead and include these since they're the only ones that looked at it in this specific clinical setting. So developing a disciplinary adequacy. So my comfort zone is more in this pragmatic paradigm of research. I would say I feel more inclined, I lean more to the subjectivity, so the subjective epistemology and relativism ontology. And you can see where I've kind of laid out psychology, public health, and medicine. The objectivity and realism of where biology falls is a challenge for me, and I definitely need to develop adequacy there. So really developing a working knowledge of the theories, key concepts, and research methods that inform a biological perspective of chronic pain and the relationship between adverse childhood experiences. Another areas that I would like to develop adequacy in is really just the quantitative methodology and research strategies. And then the biological, as I mentioned, theories surrounding chronic pain in order to develop depth and breadth in this space. So evaluating disciplinary insights. So I base this off of REPCO again, and here you can see the discipline, the model, framework, insight, and evaluation. So really quickly, biology is looking at elastic load, which is essentially saying repeated exposures to stressors wear and tear on the body's sympathetic and parasympathetic response system. But if you're only looking at this discipline and this insight, downside is that it's only accounting for the biological mechanisms related to stress and pain, right? We know that psychology contributes. We know that the environment contributes, the population base contributes to the development of chronic pain and adverse childhood experiences. So for medicine, medicine is taking this evidence-based approach to care. So it's really optimizing the quality of patient care. It contributes to the development of clinical guidelines, which is great, but it lacks generalizability, comparability, extrapolation of results. It's expensive to do RCTs, randomized clinical control trials, which are the gold standard in this space. And there can be publication bias, and then also a lag in time to publication, like after you've done your RCT and now you're trying to publish and do the data analysis. Public health, I looked at the National Institute of Health Clinical and Excellence Framework. Basically what this is saying is that individual and population patterns of disease have causal mechanisms. So explanations of individual diseases essentially can occur at a socio, eco, and political in the framework of determinants of health, really quickly. And then psychology is focusing on the psychological determinants of stress response over which we have control. and it emphasizes the personal nature and unique appraisal and perception involved in stress. So one downside to this is that it's difficult to test through experimental research because it's subjective. And then individuals may not always be conscious of all of the factors contributing them to experience a stress response. And they may not even know that they have had an adverse childhood experience or experienced a traumatic event. Integrating the disciplinary insight. So where the conflict lies. Again, the conflict lies between like biology stressing the value of classification, observation, experimental control. So in this positivism and post-positivism paradigm, medicine is prioritizing diagnosis and treatment, evidence-based approaches, considers the medical impact. So I put this in the post-positivism paradigm, but because medicine now is incorporating a patient-centered approach to research, it can certainly be in the pragmatic paradigm. And then psychology constructs the, they're looking at constructs and their interrelations can be inferred through the discussion and observation and applied to treatment. So psychology was really interesting because it can have a clinical piece. So it can be in that relativism, but also you can do a series of experiments, which puts you back into the realism objective space. So in terms of creating common ground, it's really thinking about alone biology, medical, psychological, and public health perspectives do not by themselves adequately explain or predict the magnitude of risk for pain, severity, and disability immediately and over time. And then it's really important to think about how can these biological insights, psychological insights, and social environmental population level insights impact chronic impact the pain experience and childhood adversity. So delving deeper into the sources of the disciplinary conflict, talking about more the ontology and epistemology. So biology and medicine have traditionally embraced a biomedical reductionist philosophy. It has a realist ontology, and then medicine is has a dualistic viewpoint that conceptualizes the mind and body separately and independently. So as I mentioned, I put this in the positivism, post-positivism paradigm of research. And then the methodology here is more of a quantitative experimental methodology. Public health is traditionally embracing empiricism, epistemology, and I put it more on this post-positivism, pragmatic paradigm of research. And then psychology, because it's both, it has this empiricism epistemology, so that's saying knowledge comes from or must be validated by sensory experience. So that's the qualitative piece. And then the rationalism epistemology is saying it is possible to obtain knowledge of reality by reason alone, unsupported by experience. And then all human knowledge can be brought into a single deductive system. So that's that quantitative methodology moving you over to the objectivity. So what can you do in terms of cross-disciplinary research? It's really moving to a pragmatic paradigm of research that offers an integrative view of pain and ACEs, adverse childhood experiences. And then in terms of what audiences would be interested in the research, so I have teachers here, researchers, nurses, psychologists, physicians, politicians / policymakers, caregivers of the child. Obviously the child would be another point of interest that's not listed here, and then social workers, public health officials, and epidemiologists. How can we create common ground? It's really regular integration from disciplinary disciplines does exist, so that's really important to note. However, this is very recent in the literature, like less than within the last 5 years. So biology, medicine, and psychological concepts are combined. And then there's an emphasis on, and the literature, which is important to note, they see the need for this interdisciplinary research aiming to identify causal pathways of chronic pain and ACEs. And then a collaborative communication involving stakeholders is common. However, the patient and family perspectives are missing in the literature. So constructing a more comprehensive understanding, Nelson, Cunningham, and Kozikar Zook actually developed a conceptual framework for understanding the effects of ACEs on the development of pediatric chronic pain. However, it hasn't really been used in the literature. It's only been cited in 3 articles. So that's something that hopefully later on down the line, more researchers will start thinking about this. But this model builds upon the biopsychosocial model of pain, which includes disciplinary perspective from biology, psychology, medicine, and public health. And you can see that here in the boxes. And what's important here is that incorporating the insights from the disciplines highlights the fact that chronic pain may develop from the interaction of persistent biologicals, so that's going back to that allostatic load, psychological, cognitive processes, and psychological comorbidities, social environmental stressors experienced during childhood. Reflecting, testing, and communicating the understanding. So reflecting what was learned. What we know is that a significant number of youth with chronic pain have a history of adverse experiences. And the proposed conceptual framework, which you can see on the right-hand side, outlines the potential interaction processes of ACEs and chronic pain in youth or in pediatric populations. This biopsychosocial model views physical illness such as pain as a result of these dynamic interactions. And then what's unique here and what is missing from the literature is that the biopsychosocial model of pain acknowledges individual experiences of pain uniquely and understands a range of psychological and social economic factors can contribute to the physical pathology to modulate a patient's report of symptoms and subsequent disability. However, none of the studies that I identified actually took a qualitative approach or incorporated qualitative research methods into the design of the studies to actually get the patient's feedback and caregivers as well. And then new insights gained the Sozix test. So the framework helps researchers understand the nature of the relationship between ACEs and chronic pain conditions in youth. I'll bet this is more like a cross-sectional because all the studies really haven't done prospective longitudinal studies. And those are actually needed. And then communicating the research. So to communicate effectively, we need to acquire language that allows research to move comfortably across the disciplinary boundaries. Here, complex concepts will need to be broken down into basic concepts that lend themselves to broadly shared understandings across the disciplines. And then researchers' assumptions will also need to be interrogated to move forward to some degree of clarity, really understanding if you are on one side of the ontology and epistemology, like how can we come together and really understand like what are your assumptions of the research design, all of that. And then a shared language when, basically having a shared language when communicating about ACEs and chronic pain is really, it's gonna help us move forward in this space. And then also I think it will have an uptake of people actually using this model in their research. And then questions. And then my other slides are just the references. Oh, I think you're muted.
I said, very nice, very nice. And now you can take a breath.
Oh, thanks.
Questions for Apple. First
Oh,
up,
Ashley.
very nice job. I'm sorry, Ashley, sorry. Questions? I have a couple observations, but I don't want to hog up the time. First off, I think you did a really nice job of relating these different disciplines that you found. Of course, I'm one of those half full sort of people. I'm sure you could add another 7 to that list, but you're working with a nice solid 4 different ones that tend to look at things differently. Disciplinary perspectives are not always so bounded that they don't overlap. That's like normal, so, and I think the other comment you made about in the last 5 years, you're seeing more sort of that overlap, I think is probably consistent with the way a lot of biomedical and health sciences are going. But what I gathered from the way you were presenting this material, which is the point of the assignment, is that you're starting to understand your own sort of place in all of this. And that say you were going to do this for long-term research, dissertation, or just research in general, it sounds as if this exercise has sort of helped you zero in on, where you tend to live more comfortably. And I think for all of us, that's just normal. Like, my research, I created a psychometric scale on motivation, and I'm still learning the analytic process because that's not my forte. That's why I collaborated with someone who does psychometric, measurement. So that idea of adequacy, which is an important part of all this, isn't just sort of knowing which volume in the encyclopedia to pull out. It's really more understanding where you are in your ability to understand the landscape. And I think even too, it helps you identify your biases, and which is an important part of doing research. Some of us always want to do research in a certain way because that's where we're most comfortable, but it's really the question and the problem that define the way that you do research. But I really liked how you, and I know we're all pushing to be quick here. Someone has to be first, but now you get to sort of relax the rest of the 2 hours. Does anyone have any other comments here or questions?
I just want to say, Ashley, that was a fantastic presentation. Well done. My hat is off to you. I really enjoyed it. And I felt like I learned a lot. I'll be revisiting mine later to make some changes. It was really good. I was shocked that qualitative research and the voice of the patient and the caregiver was just totally absent. Even when so many of the disciplines seemed to be seemingly present. What's going on?
Yeah, so I was actually really shocked because some of the authors I actually know. For me, it was kind of like, what's going on? But what I can say is, and what's really interesting is, at least in my space of pediatric chronic pain, I think we are, even the clinical psychologists are heavy on the quantitative piece of the research, which is surprising. Yeah. And the faculty that I work with, we're trying to gently bring in the qualitative piece, but every time we encounter pushback saying, well, that's very subjective. How do you know those themes are truly what are emerging? Like, those are the themes that you're coming up with. Even though we're saying we're doing a grounded theory and these themes are emerging from the literature. I think they really want more of like, how can we prove it? And I also think from their end, since psychology is kind of, it's not like biology, so people already have their bias and assumptions that it's going to be a soft science. So they're trying to beef it up by adding this quantitative component. So
I have to wonder how much,
because obviously the patient.
You think?
Oh, I'm sorry.
Oh, no, go ahead.
How much of that do you think has to do with the fact that you're in a hospital-based system? Mm-hmm. You're in a hospital, right?
Mm-hmm. Yeah, I'm at Stanford. Yeah,
that's right.
Yeah, I think it actually probably is.
Yeah,
probably. And it's an academic center too. I think if it was even outside of a hospital, maybe even if it was like at Kaiser, it might be different. But because it's an academic medical center and the faculty are doing research, but they're seeing patients, but they're still going for professorships and they're still trying to, get tenure if I'm working with assistant professors. And I've seen you're not going to get tenure by doing this qualitative analysis. Well, they really want you to.
There's some truth. There's some truth to that. It's not right, but Hannah, go ahead. What were you going to say, Hannah?
Well, it was curious because that was something we had an issue with in childhood obesity too. And I wonder if it's like the vulnerable population aspect of working with children, especially those in chronic pain. Which is just an issue. I don't know if certain disciplines are better about how they handle it, but I know, in medicine and academia, if it's easier to kind of not have to deal with the hassle of that might incentivize people not to include them.
I can definitely say adding the child and the parent, it's difficult dealing with parents when you are doing research with the child. It's actually way easier in my space to work with the child. It's adding the layer of the parents. So sometimes I think investigators are like, I think let's just go ahead. We can use the clinical observations that we have and the EMR versus like going directly to the patient. Also, qualitative analysis it's a lot of time and effort, and they don't want to do that.
And Ashley, just a note, and this doesn't have to be for this specific project, but look into the HERN model. It's the Health Experience Research Network. So it's something that was developed in the UK, and this whole framework is meant to give voice to the patient and caregiver, specifically in the clinical setting. That's where it originated from. And so there's about, I think maybe 4 in the it's starting up in the US. And so our own Children's National is looking into expanding on that too. The first module is looking into expanding it on, I think, rare kidney diseases or something as a focus, but there's some work in trying to give that qualitative voice, like in-depth qualitative voice. So
yeah,
really cool.
I just wanted to add that I think something that I don't want to pigeonhole this particular project, but I always think, especially when it comes to pediatrics, I think culture and social studies, meaning studies of society, often play a bigger part than we give them credit for. Because, of course, a child is a hard participant to do qualitative work with, because sometimes they're just not developmentally ready to express themselves in the ways that we like to think they could, right? But I think what is always fascinating to me, especially when I was in a children's hospital for many years, was you can almost observe, without even being in an exam room, the differences culture play in the way that child health is managed. And I think probably in this case, it's probably no less than any other sort of health condition, that I think there's always a factor when you're dealing with pediatrics where how the family unit is constructed, what the traditions, and when I say traditions, I don't mean just sort of cultural traditions, but even health traditions, and how oftentimes, especially with children, certain types of problems are managed by the family. I think that always plays part. And that would get into what Sarah was saying about the lack of sort of patient engagement. And I think, I'm often usually the person in the room that says, have we included the patient? As if, they're missing. Now, there's no discipline called being a patient, right? But there is that socioeconomic, cultural factor, which is part of the different disciplines that we tend to use to understand problems. So I would always promote that. That's something that I think health and biomedicine are sort of catching up to. It's taking some time, but I think that's something that, we all should be conscious of. And I think especially in pediatrics, because we have children who are reared by other people. They're not making all their decisions independently. They're part of a unit, Sarah, were you going to say something? You looked like you were going to say something.
I wasn't, but I was thinking about something, so maybe I was making a interesting face. I was just thinking about, Ashley, now the challenge that lies before you is you have your understanding of the different ontologies and epistemologies, and how are you going to convince, find common ground in a setting where the ontology is like very, very set. And, I was just thinking about, even within that, there's like looking at pools and looking at, sort of like the conflict, the power conflict aspect of that, right? And like, where are you in the food chain of, the management, and how do you convince people who are above you? So it's a really interesting,
Yeah, that's a good point. We've started working, the faculty member that I'm working with, she's in alignment with me, which is great. We're actually using photo voice, which is used in public health, to really try and provide that child's perspective of what it's like living with chronic pain. And that's been the most impactful, I think. And it really gets people that are in this quantitative research space to really take a step back, like, oh, wow, this is really, and also it's the language, like to what Dr. L was saying, a lot, by the time patients come and visit us, they've visited multiple doctors that are saying, oh, the pain is all in your head. It's not real to a child, right? So it's really trying to provide a voice for them in this framework. And that's been really impactful.
That's amazing. Wow.
I don't want to stifle conversation, but we want to keep moving. That way we're not here till 11 o'clock. Excellent presentation, Ashley. Thank you. Great comments and questions. Remember, when you post your critique, your response to these on the discussion boards, feel free to continue these conversations and learn from each other. Thank you, Ashley, very much. Apple, you all set?
So yes, hi.
Hi.
So this won't be as great as Ashley's, but give me some feedback. So just to give you a background, I'm talking about, the title is Two Generation Approaches in Maternal Child Health and Occupational Therapy. One of the research question that I have came up with is, how can two generation approaches combining parent and child interventions be applied in maternal child health and occupational therapy? So just to give you a background, health and well-being of the child is influenced by the environment, and most especially the health of the caregiver. The healthcare systems recognizes that there is a big stake when the health of the children are compromised, without taking into consideration the siloed systems that are in place that contributes to the decline of health of our children and the next generation. So two generation approaches, which are the methods that combine parent and children interventions, have been used to address social health, social capital, and economic impacts that are handed down from one generation to another. The role of early childhood experiences is crucial to the overall child's health and development, while approaches that support the integration of care and support the mother, the parents and children are emerging in public health and public policy. The implementation of these approaches is parts in maternal child health and occupational therapy literature. Next. So why a cross-disciplinary approach? So the problem needs an interdisciplinary approach to develop a deeper understanding of the problem. So addressing the health and well-being of mothers, infants, and children is complex as a complex public health goal of the United States, as stated in Healthy People 2020, and it can help predict further future public health challenges for families, communities, and also burdens our medical care system. So moreover, healthy birth outcomes and early identification can also prevent death and disability, and help us enable our children to reach their full potential. So various disciplines have tackled these issues, including medicine, psychology, public health, early childhood education, nursing, and public policy. But then still health outcomes are not improving. 20% of mothers experience mental health conditions after childbirth, and 10% of babies are also born prematurely. So as occupational therapists who work with babies and children, we have not really tackled into looking at the health also of the mothers that are giving the care of their kids. So I looked into the relevant disciplines that may be applicable. There's medicine, public health, public policy, early childhood education, psychology, and occupational therapy. But as I looked into their perspectives, primary care medicine really is integrating public health and behavioral health within the community. So I think it started in 1978 based on the declaration of the Alma-Ata Act from the World Health Organization. And I think all the countries have tried to develop this a primary care model, including the United States and other developing countries. Public health, this is also without looking into a lot of details, of these perspective. I thought that I could combine public health and primary care medicine together, just to really, because they're sort of overlapping perspectives. I also included public policy, early childhood education, because most of the two-generation approaches have been done within the early childhood setting, where funds are really allotted in early Head Start programs, where children are receiving early childhood education, where their parents are also getting vocational schooling and a lot of livelihood programs, so that to get them out of poverty. I thought psychology is also a good perspective to include, and also occupational therapy, which is a more holistic approach. And there is some bias there because I am an occupational therapist. So, and I do want to include a more interdisciplinary perspective into how, in the settings where we serve patients. So yeah, so from all the six disciplines, I just included public, I went down to 5. Literature databases, I had struggle. I had a huge struggle in looking at literature. I sought out for the help of our librarian, Anne, and I was able to take out at least 15 articles. But most of the articles that I really have looked into are from looking at the references of the identified articles, and so that I thought that was a very difficult. That was the most challenging part for me, is looking at literature, because number one, occupational therapy is a very new field, and we're also very siloed. And so one of our challenges here is the two-generation approaches is research in public health and policy, and economics, not really in health, limited research in the United States, more research in low income and middle income countries, which doesn't make sense to me, because they have less spending money, but they also they're able to really address this. I guess it's more cost saving, but I don't know why. Maybe because we have been really looking at more health as more the curative model of health here, and where physicians or practitioners are compensated when they see someone to help them. And so I think that was also like that one challenge that I have, because of these differences. I can't really find a lot of research here in the US. Silos in occupational therapy research. Occupational therapists just like to talk to each other. They don't like to include other disciplines. More so now it's getting better, but I think that we need more help, and we need to do more of that. And the systems that involve child and parent interventions are fragmented. And so I thought a lot of these the specialty care center, and also the diminishing the value of family medicine, I think is also really have been some of the challenges that I have seen here. Adequacy. For adequacy, to develop adequacy, I looked into the literature and decided which disciplines perspectives are most applicable. And so I learned into my own epistemological assumptions and considered also the others. I am more comfortable in more pragmatic mixed methods research, but I also realized that in public policy, where dollars are involved, it's more quantitative, and I don't really know a lot of those a lot, and I hate economics. And I also I'm in this job of helping others, not making money, and so that was really that was very hard for me. Getting there, I have to read a lot about it, a lot of health economics, public policy literature. I also I'm more in this middle, the middle section where they're more pragmatic, and so I lean towards my experience in community-based participatory research, a lot of qualitative, and also the mixed methods approach. So this disciplinary insights. Oh, so what I did here is I extracted the insights from each disciplines, and I put it in an Excel spreadsheet. And so based on their theory, their key concepts, their method, based on the book, Repko's book, and I recreated them, and put it in this this slide. So based on my readings, one primary insight here was like primary care is a one-stop shop. There's more generalists, not special, that specialists, but then what they do when they need specialty care, they refer it out of the community. Integrated primary care is a lot more cost effective, and the two-generation approach are more common in developing countries and not in the US when it comes to health. Occupational therapists also have this siloed approach. They only see the child without even considering the parents, and although they think about client-centered, family-centered approach, but really they don't look into the other factors that contributes to the health of the moms and the families. Public policies, it's more about raising human capital and economic stability, and also increasing parent involvement. Early childhood intervention is also early childhood development perspectives. The insight that I've gotten there is just schools are not places for formal education, but also places for childcare, and also family services together. And psychology is also talking about the impact of parenting stress, and I think Ashley had alluded to that, adverse childhood experiences, and also the building of positive attachment for parents. And so I think that is also something that is what I got there. Conflicts between insights. These are so a lot of these disciplines have conflicts based on their epistemology and ontological approaches. In psychology, the conflicts is there. It is mental health it's focused on mental health interventions rather than prevention. Primary care focus in general versus specialized care. Occupational therapy also has these conflicts on parents play a role in therapy, but the parents are not considered. And childhood education is really focuses on childhood care. And public policy in itself is also focusing on possible outcomes for the next generation, more of human capital, and not really about everything else. Sources of conflicts. These are, I have looked into looking at the values of public policy, where, public policy is thinking about the value of money and economic progress, economic human capital. Psychology is also like looking at the fragmented healthcare, and primary care medicine, also the fee-for-service based primary care medicine. So also thinking about that. Also, early childhood education, the conflicts lie in increasing parent self-sufficiency, but the programs are underdeveloped. And occupational therapy is a lack of knowledge of OT and the role could play. So yeah, so those are the conflicts that I have found based on the values that are placed within these disciplines and their ontology and their epistemology. creating common ground. And so to create common ground and based on REPCO, I was able to set theories and also modify them through their concepts. So I sort of took out their concepts and put them all together and put a stamp on where they can, where I found a common ground in and which disciplines that are, and I thought that these are the public the disciplines that where we can find the commonalities, and they looking at this perspective, they were looking at really the the combination of the biopsychosocial approaches and the ecological the socio-ecological framework. So in the understanding the problem, I was able to graph out the different four theories of these of the insights of each of the commonalities of all disciplines, and I was able to track that the most common theory that they can that I could find for them, that they're all aligned, where I can find alignment, is the life course health and development theory and the social ecological model. Which brings me to this next slide, which is I am able to understand the problem using the a combination of a biopsychosocial model and the socio-ecological model using this life course health development framework that was created by Halfon and Hawk's team, which luckily I didn't have to create this framework anymore because it's already created. And also I have found that the Health and Human Services Agency has also developed this framework and used this as an infrastructure to for their strategic plan in the next few years as they build programs for maternal child health. And so this is a combination of epigenetics and going through chronic conditions later in adulthood, also considering also inequities and the social determinants of health and also the social ecological framework. Okay, and then lastly is, so while I was looking at reflecting, testing, and understanding, some insights that I've got, that one commonality is mental health is a bigger, that maternal child health is a very, very broad topic. And so I really needed to hone down and really think about maternal mental health, because across the board, that is the big commonality and a big problem, public health issue. And so I tried to just tweak my, the question into like 2-generation approaches in occupational therapy as an interdisciplinary perspective. And so, you know, thinking about how can others help us think about how occupational therapists can help in this solving this huge complex problem. You know, in testing, it allows for action useful to the public and solves the problem. So I thought the biggest issue here is that the lack of integration, but also the lack of human resources that can help. And so I thought occupational therapy, which is also this bias that I have, that could be a helpful workforce that to support the mothers of the kids they I already see. Another, the communication piece, to communicate across disciplines, I like to use the metaphor, right? Like the airplane metaphor, where you save yourself first before you save your child. And also another metaphor that I thought about is the candy wrapper metaphor. Like, you know, when the candy is wrapped, and when the mom is still pregnant, a lot of care is given to the mom. But when the mom gives birth, it's like a candy wrapper. You throw away the wrapper and you pay attention to the child. And so I guess this is one approach to unify everyone, that, you know, health begins with the health of the moms, you know, and also all throughout, and which can also contribute to the health and the well-being of the next generations to come. And so, and lastly, I am gonna, to contribute to my understanding, I'm gonna study the framework, which is the life course health development framework, which has already been done and studied. And so I just really wanted to apply this framework and how this can be used to within the occupational therapy practice, but using more of an interdisciplinary perspective. Thank you. Any questions?
Very nice. Thank you. Great slide aesthetics too. Those are fun. You brought to mind something in your presentation that I just want to mention before I forget. When we talk about a spectrum from a positivist to subjectivist sort of spectrum, yeah, we can say that some disciplines are more heavily grounded in one end of the spectrum or across the spectrum than others. But we can also see how within certain disciplines there is that spectrum as well. So it's interesting, Apple, how you were saying that psychology sort of ends up on the squishy side, right? Compared to some, but it was Ashley who was talking about how psychology, the discipline of psychology in her environment was much more, I don't want to say positivist, but more measured, So while you're considering where these disciplines might fall in that spectrum, realize even within disciplines, there is that spectrum. And I think the other thing I wanted to mention, and I'll let other people make their comments, was that when you include a therapeutic discipline like occupational therapy, physical therapy, art therapy, you name it, okay? Therapeutics are a little different, and because they tend to try to embrace holism, I think, this is my opinion, than some of the other disciplines. And I would say of all, occupational therapy is probably, at least in the health therapies, probably most like that. So you have to ask yourself the question, is there something going on in certain disciplines that actually is a model or a monicum on how the other disciplines can integrate? Okay, so, think about, if we have some disciplines that are just so starkly, bounded, while other disciplines we're working with are less bounded, that Venn diagram, that visual I'm, was talking about, those disciplines that just by nature are less bounded may actually have more to do with the overall perspective because they have that wide, array of looking at a problem. But I'm going to stop there. Other comments or questions from anybody?
Dr. L, thank you for that comment, because I also realized that as occupational therapists, we just like to talk to ourselves because nobody's listening, right? And so we just like to talk to ourselves, and it's hard for us. And like when I started working, and even up till this point, people ask me like, what, do you help people find jobs because you find occupations? And so that is also the big challenge. And a lot of therapists just put themselves in that comfort zone and not be able to talk about and deal with those comfort level. And so really this is a very good exercise for me because I'm looking at it from a different perspective.
But some of that comes from when we talk about conflicts. The conflicts are less, what Repco and Stotek means by conflicts are less the conflicts within a discipline, but the conflicts across disciplines. So conflicts can be where, psychology, disagrees basically with what biology might say. I mean, they just look at it so differently. It's a conflict. It's like hard to imagine how you can balance those out. I think in the case of occupational therapy, what I know about occupational therapy, it's slowly over the years starting to realize that it needs to communicate in a way where other disciplines can understand it, because it is unique. Like even, the difference between physical therapists and occupational therapists, sometimes they talk across each other, So that's really draws to that issue of conflict, when we have a problem understanding how one discipline uses its vocabulary, what its values are, what its base epistemology is, and the communication necessary to talk to another discipline. By the way, when you get a little further in your research endeavors, these places where there's no connection, like where there's a gap, is where your best research questions are going to be. Nobody wants to research something that everyone already takes for granted. It's like, who cares? But when you do this sort of exercise, you say, wait a second, I can make all these connections, but why don't these two things connect? That's where your best research questions are going to be. Not what you find, what you don't find. Yeah, go ahead.
When I use MASH, occupational therapy, and maternal child health, nothing comes out.
Yeah.
That's so crazy.
Which probably means you either need to think about the common language. Maybe you're not thinking of the common language, or maybe there isn't any common language and you have to think more creatively.
Occupational therapy needs to change its name. I think that's what it is. No,
we'll let you take that to an AOTA meeting. We'll let you do that. Hannah, go ahead.
Occupation, the word occupation does not exist in other cultures.
I'm sorry, say that again. What was that, Hannah?
Oh, I was just saying genetic counseling is like that too, where we kind of bridge other things. Yeah. And then some people think we're counselors and other people think we're geneticists, and we're trying to like merge the two into something new. So yeah, I have to do a lot of that.
But don't take away from what I said that that's a bad thing. You're bridging.
No,
like, you're bridging.
I have a lot of communication skills because of it.
Yeah, no. Yeah, right. I mean, the idea here is, there was a time when we didn't have something called nanotechnology. And now nanotechnology is an important part of the entire field of any technology, because we can make things much smaller and we can figure out how they can even enter the human body, et cetera, et cetera. That's what this exercise is meant to sort of juggle in your head. When I look across disciplines, where are the holes? I call it the holes in the cheese. It's basically a piece of cheese, but it's in those holes where things don't connect, or where the words don't overlap, or like Apple said, there's nothing comes up in the mesh. It's like there's nothing there. There's nothing related. That's where research occurs. And once we realize that these are disconnected elements, that's our job as translational scientists, is to figure out where the points of contact are.
So I may not call myself after this program. I may not be an occupational therapist anymore. I'm going to be a translational scientist. So
that's going to be the name. That's going to be the name of your degree. So get used to it.
And I mean, Apple and who was it, Hannah, that said like your disciplines. Like I honestly would say public health was like that. Not too long, well, longer than your field, but it was like that at the start too, because I remember when I was doing my undergrad, which was a while ago, like public health was not really a thing. Like we knew what was happening in it. We knew it was kind of medicine, kind of psychology, some sociology, right? And it became this mesh of things too. And it took a while for us to find some of the terminologies, the theories we adopted from the other fields. So maybe it won't be long before your fields, end up just being more exposed. So.
My favorite thing now is that I am co-chairing a public health genomics working group within the Genetic Counseling Society. So now I have to explain what public health genomics is to people.
That's awesome.
Even that in itself, the challenge to know enough about what we know and know enough about what we really don't know completely is a stretch. Every once, it's okay to pick up somebody else's literature. I think, Apple, you were referring to how occupational therapists don't tend to like to do that, but pick up somebody else's literature that you would have normally said, ugh, I don't want to read about public policy, you know. But once you go down this structured path, that you have a problem and you don't just base your approach on your interest or proclivity, but you look at it based on what's necessary to solve the problem, it changes the way you approach these adjacent disciplines. And by the way, we're still all talking about health related disciplines. I mean, imagine if we were talking about physics, occupational therapy, and some sort of a technology, you know, which, by the way, is not hard to imagine as an occupational therapist. That's even more confounding. But this process, this activity is meant for you to say, okay, let's not run it the way Sarah, Apple, Ashley, Guy, Hannah, or Daisy would. Let the problem run the process. It's a little different than we're all used to because each one of us was trained in a particular field.
Right.
But once you look to being translational and cross-disciplinary in your approach, you let the problem guide the process, not our own interests completely. But
Like with dissertation.
Mhm.
That's what we tell
Pardon me?
our students about. I tell our students that about their dissertation too, because people come in comfortable with certain methods, right? They call themselves either qualitative or strictly quantitative, for example. But we keep having to remind at least our students that once you determine what your research question is, you have to use that to guide what is appropriate to carry out your research, right? Not just about comfort. And I mean, yeah, that'd be great. You finish on time probably, but that's not really the purpose of a PhD,
Yeah, good scientists follow the problem. They don't follow
Mhm.
their heart. They follow the problem and let the problem dictate what they need to do. We need to stay on time. Another great presentation. Thank you.
Visuals.
Thank you very much. And I think Hannah's next. Do you have access to?
Yeah.
Oh, you do. You're right there. Okay.
Yeah. So I'm running into a lot of technical difficulties. The video
Okay.
keeps freezing on everyone every few seconds. So I figured out how to call in. So I think my voice should be stable, but
Okay.
I
All right.
guess it's
We'll deal
working
with
or
it.
not.
If it's necessary, and if it's necessary for me to put up your slides, I will. But let's try this first.
Yeah.
So far, so good.
Can you see my?
Hmm?
Is it
Yep.
Obama?
Yeah.
We see Obama.
The
Yep.
Obama pre-election of when things were normal. Okay. So I was actually really happy because our reading this week talked about the Precision Medicine Initiative. It was the article by David Chambers, who has kind of spearheaded the idea of using implementation science and genetics for my field. So hopefully I don't have to introduce this initiative too much, but it's been around for decades, really since the beginning of the sequencing of the human genome, but Obama made it one of his initiatives, and now it's called the All of Us program, where it's really this idea that everyone in the future will have tailored medicine specific to their predicted risks, or if they do develop disease, specific to the disease that they get. So this very lofty idea, and a large crux of that is based on genetics as a clinical tool. So I think David had highlighted in this paper, there's a lot of questions around how you actually implement that. So my talk today is going to be focused on implications of implementing clinical genetics as part of routine care. So making it part of your everyday workup with a doctor. What are the challenges with that? And he discussed in that paper many implementation aspects you need to consider, like the infrastructure of the healthcare system. But I'm really trying to take a step back here and really just focus on the need to even have an interdisciplinary concept of how we think about genetic identity. Because I think we tend to move forward in medicine when something's available to just kind of run with it. And we focus so much on the clinical utility that we've demonstrated, and we don't even think about how other people are interpreting that. So hopefully today I can show that this is very much an interdisciplinary need. But before I go into the problem, I did kind of want to demystify some of the jargony concepts that my field tends to use, because they're pretty important in terms of assumptions for this whole precision medicine idea. So one is just the concept of clinical genetics. That's the focus of what I'm talking about today, and that's simply just distinguishing genetics based on health risk So ones with that medical need and that being assumed, because genetics has certainly been used for things like your ancestry. I think some tests are there for like your intelligence and all these other stuff. So those use cases each have their own kind of like ethical questions and context associated with them. So it's really important to define your use case and make sure you're operating with that assumption because it is quite nuanced. So that's what I'm focusing on today. I've already talked about precision medicine. One other aspect I want to highlight is that the key thing here is it is really moving genetics, which is historically on rare disease, into the public health domain because we want it to be part of everyday care. So that opens up a whole can of worms that the field has not historically dealt with. And that kind of touches on this last point, the most important one that I've highlighted here, that we're moving from rare to common disease. Where, you know, before in the past, genetic diseases were very obvious and children that had, you know, developmental delays were very sick. That's what we historically would treat as genetics in clinics, but now we finally are having the technology to quantify genetic contribution to common disease, which was a little bit harder to assess because it's variable from environmental effects and other things kind of impacting health. So it is really this technological advancement that is now making this idea of precision medicine really actually feasibly available today. And that is kind of the prompt for me starting to think through these questions because I'm certainly seeing that there's already this push to drive this forward. So for my slides, I'm a thematic thinker. I think that will be obvious throughout. So I've clumped some of the slides together more into themes that made sense to me, but tried to highlight what I was getting at. So in terms of just helping to define the problem, I've already discussed this background of moving to common disease and the implications that has when you move from individualized care to public health. And the problem that this presents then is that really we don't have existing policies in this field that sufficiently address broad implementation because of those historical silos of disease, which was fine when you were dealing with one-off patients, but when you're thinking about public interest, you really do need a system in place now. Despite not having that system in place commercially, it is very much being pushed forward, and I would say clinically as well. And you, I'm sure, have read in the media horror stories about different genetics things that kind of reveal the stress points of the system where privacy was compromised or someone had psychological harm. So this really leads me to my main kind of focal question here. That if we want to move forward with precision medicine, we will eventually be medicalizing concepts of genetic identity and making differences between people something medical. So we really need to understand what the broader implications of this are, ideally prior to doing it, but we're kind of already in it. Because when we are thinking about this at the public scale, the potential for harm is greater and needs to be avoided. Especially when the things that we're thinking of like heart disease and stuff like that are common and don't necessarily have that genetic label in today's society. So, my clicker isn't working. Uh-oh. Sorry, there we go. Okay, so the reason I thought this was an interdisciplinary problem is again, a lot of the push for this comes from medical concepts of genetic identity, which are housed in kind of a biological discipline. But genetics as a concept has been around for a very long time, for centuries before the technology was ever there. And it has ties to many individual, social, cultural perceptions of identity, you know, family and ancestry being examples of that. So medicalizing genetics does have repercussions on those other areas of well-being and, you know, self-perception. So it's really important, or I think it's really important to make sure there's alignment in concepts of genetic identity rather than this purely clinical definition to inform future public policies in order to avoid those unintended repercussions of medicalizing this information. So that, with that kind of focus in mind, I had moved into my literature review, focusing on looking at concepts of genetic identity as it relates to health or perceptions of self from different disciplines. I have looked primarily at Scopus and PubMed for these disciplines, which I'll show in more detail in the next slide. I also looked at PsycInfo, but I felt that the psych and literature was pretty well represented on PubMed. And it was just a very preliminary review looking for these concepts, but I have the full results in search available in this tab that I think I had emailed everyone the slides. The main takeaway, though, that I was encouraged by is that most papers do acknowledge genetics is a cross-disciplinary problem and even suggest areas for collaboration. This is really encouraging. I'm going to talk a little bit more about my challenges with the process, and then I have tables later on that actually go into the details of what I found. But these were the disciplines that I had looked at. The ones that are bolded are ones that I thought were most relevant, and I will show details on why that's the case when I show those tables later on. Looking at these disciplines was informed by personal experience, but you can look at a lot of the opinion pieces on this topic, and they will usually note some combination of these things being of interest. So before I go into my thoughts on the process, I also wanted to flash this little diagram that the others have shown, because I was basically jotting notes of what I found really difficult during this process. And then in parallel, we had an exercise in foundations where that really helped me realize there were themes in what I was struggling with. So these were that for disciplines that had more of a constructive perspective, if I did not have prior background of theories, I really struggled to follow it. So my weaknesses were areas like political science and economic theory, whereas I have background in psychology, anthropology, and sociology. So those were really a lot more interesting for me to read and follow. So that was a prompt for me that maybe I should just do a general search into those disciplines and theories in general, just so I would have more reassurance that I could fill in gaps that I wasn't getting, especially because I am such a visual thinker. I also realized the quantitative methodology is not my favorite, which is kind of surprising because my training up till now has been very much rooted in natural sciences and quantitative methodologies, but I did not give credit to, decades of being exposed to that really helping me. So when I had new areas like stats and economics, that was kind of went over my head a bit. So I'm realizing that weakness of mine. And my last challenge that I had was just difficulty in identifying things. The insights were not always readily apparent to me or explicitly stated, neither were the assumptions. But I also felt like looking into background theory would, again, help me to extrapolate and kind of read in between the lines a bit. So that leads me to the adequacies, where, again, after I read the background theories, I did notice that improved. And I was able to extrapolate the insights that I'm going to present in just a second. And that is kind of aligned with a strength of mine where I tend to think pretty big picture and connecting things. So it's not surprising that I needed that foundation to really follow new topics. One kind of remaining challenge area for me, though, is I struggle with misleading linguistics, especially in my field. People tend to use terms that they think mean one thing and it doesn't mean that. Genetic identity is actually a perfect example of that, and at least I'm familiar enough to recognize when they mean it but aren't saying it, or saying it and not actually meaning it. But when I came across things in other disciplines like culture or power conflict, I have my biased opinion of what that means, but felt that I didn't feel confident knowing what that discipline meant. So that was something to be mindful of, and something I struggled to really sufficiently address for adequacy in this short exercise, but think that having a team and more time would really help. So that's good to know for the future when I engage in these kinds of research projects. Okay, so moving into what I actually found then. So I have basically a table on each of the 4 disciplines that I focused on. So sociology, biology, political science, and psychology. I did send these slides because I probably can't go through in full detail, but I've basically organized it by the discipline, assumptions from Repto, insights that I had extrapolated from the literature with different citations, my assessment of what that kind of meant for maybe the field overall. And that was typically based on those parent theories that I ended up needing to go back and kind of inform myself on. So for the purposes of leaving discussion time, I'll just focus on the key takeaways, but please feel free to go back to my slides that I had emailed out if any of this is interesting to you. Was really that the the individual perceptions of genetics is really influenced through a filter of social and cultural norms or attitudes towards genetics. And in the context of health, the societal kind of attitudes towards the causal role of genetics really plays a role as well. So I have an example here. I think I have it here. Maybe I forgot to put it. There are some cultures that believe cancer, for example, is attributed to stress and only stress. So you tell them genetic information and they don't believe you, they don't act on it. So things like that really impact both the interpretation of genetics and then how they choose to act on it. It is a bidirectional effect though, where individual awareness, kind of at the individual scale, at a tipping point can then shift the cultural values and norms with time. So you might see a generational effect of those attitudes and causal perceptions changing. So that was kind of the key relationships between genetics and identity and health and sociology. Very much like a very rational field, fact is fact. So if the genetic change is there, that's all it is. It is what it is. And it is just a foundation for an accurate diagnosis and treatment. So logically then, this adds value to patient care and is helpful and should be acted on. So there's not really any kind of interpretive value added to this. Political science, my key takeaway here was that power dynamics really dominate. I forgot to mention, I did end up collapsing some of the disciplines that I felt shared really common assumptions and kind of theories. So political science, I'm saying, focuses on power dynamics, but that was also reflected in anthropology and economics as well. And I think that probably makes intuitive sense for people. So then applying this insight into the field of genetic identity and how people are thinking about this information, it's really saying that genetics as a tool in clinical care is pushed by those in power, people that want to know the most about their health or want to profit off of it. And that is concerning because often the ones that's concerning because it can worsen health disparities. So those that are already in existence, you can imagine that if those in the kind of advantageous groups have access to it, those without access will continue to have worse care because of an access issue. But genetics also historically coincides with marginalized groups, so racial minorities or disabled individuals. So without proper protections in place, there's really a concern that genetics will reinforce these social hierarchies, both from a disparities perspective, but also just in the way that we are grouping people and now adding an additional label to these social labels that have existed over history. So I would say the general tone from this discipline is one of caution and one needing to be proactive about privacy and protections for groups. And then finally, psychology. My key takeaways from this discipline in terms of how their insights apply to genetic identity and perceptions about genetics. Psychology really supports the fact that people are kind of curious about themselves, and genetics is one way to learn more about yourself. So for them, it's typically that the people are receptive to this information, but the caution here is that you need alignment of that new kind of mental construct with the rest of that individual's illness perceptions and just psychological constructs in general, because genetics could influence behaviors and how people cope with information. So there's an emphasis on interpersonal interactions to explain information in a way that is aligned with the patient's personal values. So I would say this is a bit more optimistic, but again, cautions against pitfalls if you're not totally aware of the repercussions and kind of mapping of where this information fits in with the entire schema. So all that to say, my summary is that I have conflicts on this slide, but I actually don't think they're conflicts. I just think they've tended to clump into two kind of different schools of thought that aren't mutually compatible or mutually exclusive. So one area where there tends to be this clumping effect is in the perception about the role of genetics in health. So there are disciplines that tend to think of it as deterministic. And these for me were really the natural sciences, which makes sense because it's born out of positivism. But there are other disciplines that have more of that interpretation added to genetics where, genetic information by itself, not helpful, it's what people add on to that and what values they give to it that actually matter. So these were more of the social sciences, which again, I think makes sense based on the epistemology. The second area where there was kind of this clumping difference effect is how people then use that information. So some theories and disciplines really hone in on rationality. So biology, political science, there's a cause, there's an effect, that there are things in place to predict. Other theories though and disciplines, they support more variability. So there's still a value of prediction, but they're very much open to context, and every person or society is kind of different. So those are really more of the sociology and psychology perspectives. So there's not like a clear clumping where everyone's kind of on one side or the other. Some have commonalities between each other. So I really felt that this was encouraging, that there's an opportunity for better understanding here. Because if you look at the source of these conflicts, I really do think it's differences in assumptions, but because of different values. So I have a quote here from the book just to refresh you on what that means. But I think the key takeaway here is that when disciplines have different values, and their theories are going to be biased towards studying certain factors. So the issue is more of a lack of recognizing or studying other things rather than, saying that it's false. It's more that it's negative because it wasn't looked at. So I think there's an opportunity here to combine different concepts and just have a more holistic, expanded model that addresses those two areas of the differences, which is how the information is perceived and then how the information is acted on. And visual models might help because there's a natural kind of relationship in that if they're acting on information they receive. And I think all disciplines, given the support they had for collaboration, would support this, especially because all of them do value the ability to have, accurate models and really understand phenomena. So I do think this is encouraging for future alignment. So on these last few slides, I did try to just put it all together and synthesize it. So thinking about common grounds then, again, thinking about those value-based assumption differences, I had said on the previous slide, just consider maybe combining all the constructs and seeing where that fits. But that in itself, of throwing all these things together, is probably not helpful. So it's good to create purpose and establish those relationships and have a reason or thing that you're working towards in those relationships. So Poole's perspective of functional, like a functional goal that helps to bring groups together, stood out to me, because I think all these disciplines, because they value predicting behavior, decision-making models of health, could help to get some people to kind of all coalesce around a shared goal. And finally, when making those relationships, my observation from the literature is that it seems very bidirectional and there might be feedback loops. So I saw some overlaps with this potentially being a complex adaptive system, but I would need to explore and have more of a deeper review. But that is one caution I have against the model, that a simple model might not work. And I would just like to highlight that this, I think, is already starting to be thought about. So this is one model that I like that already exists. It's the society behavior biology nexus. Really, this is all the constructs that I mentioned together. They're just kind of thrown together. There are some relationships, but not really well explained. So the next step would be to add that decision-making aspect to it and try to focus on relationships between things. Which leads me to my last two slides of just what are those relationships? What is our understanding after this review? I have the original problem here, but the key insights here, biology is kind of where I started. I do think that it offers a valid insight into the role of genetic mechanisms for disease and could potentially be a useful clinical tool. But rather than assuming all the logic of clinical care follows, I think the other disciplines have really highlighted that it is much more complicated than that. And once that genetic information is available, it's very much subject to social, cultural, and individual interpretations of the information, both in how they perceive it and how they act on it. So it's almost wherever biology ends with producing genetic information, you kind of have to subject it to the greater social context in terms of understanding how it will actually be used. So that is how I kind of see those things transitioning. Now, where those different constructs interact, I think I'd need a little bit more time to work through actual arrows, but this was actually reassuring because this was kind of an intuition I had during my thesis with my master's a few years ago, and I hadn't quite gotten this far into the interdisciplinary work. But in this model I had around genetic testing decisions, I had these disease experience constructs based on the biology and psychology, and added ones that were about social and cultural belief formation, and thought that those might both help to predict, behaviors around getting genetic information and then the behavior acting on that test information. But I'm realizing now that there would also you'd need to study the impact to the system, the public health system, how it changes attitudes in general, and how that then feeds back into changing these upstream attitudes and perceptions of illness. So I think my field of genetic counseling is encouraging. We've looked as far as psychology and biology. Those in public health, I think, have started to think of social aspects, hence the public health genomics group I talked about. But I think it's reassuring, but there needs to be a lot of work done. And another complication potentially for the future is defining the unit, where we've typically focused on individual units, but for public health, populations are typically the unit. So you'd want to think a little bit about whose behavior you're actually assessing in these relationships. And that's it. These are my very miniature references to fit them on the slide. But
Very nice, Hannah. Thank you very much. I just want to make a couple comments here. Don't take your slides down quite yet, Hannah. Would you go back to your final model, the one you said you were building on from 2016, I think the date was. Just put that there for a second. So I have a couple thoughts I just want to share with everyone. First off, no one is ever going to count up how many disciplines you consult. That's not the point. That's not the point. No, I'm not saying you did that. I'm just making that as a general statement. I look at cross-disciplinary work and model building as like a recipe. You use a half a cup of psychology and a quarter teaspoon of genetics, and it's not all things being equal. It's the combination that brings to light what is going to impact the problem in the way that you're looking at it. So I think one thing we have to be careful of always is that we don't make all things equal. All things aren't equal. Okay. The other point I want to make is in some of these disciplines, we need to remember that not all, let's use psychology because that keeps coming up over and over again. Not all psychology is about the individual, nor is it about, psychosis, the psychology of an individual. We have social psychology, we have industrial and organizational psychology, we have all different kinds of psychology. So as you go deeper into whatever you're studying, you're going to find that there's a lot of different types of genetics. There's a lot of different types of whatever. And as you get deeper into your own research, this concept of adequacy is understanding the differences and where to look and when to put them together. Now, modeling is one of those things that is the direct results of looking at different ways of looking at a problem, or different ways, and sometimes I call it managing a problem, where you put together pieces that are from different disciplines. The last thing I want to say is there's this little catch-22 between recognizing that different fields and disciplines use different language and homogenizing it into a single language. This is where disciplines stop communicating well together. And yes, I have an anthropological, sociological background, very much like Hannah, right? And we make up words all the time. We just decide to make them up and they're wished into being, because that's the way we tend to look at the world, I guess. But be careful, because some of the barriers between disciplines being able to cross over is because adjacent disciplines don't respect that language. So as Hannah said,
you have to know.
Yeah. So as Hannah said in a couple of times in her presentation, I have my own biases as to what that means because my field defines it this way. but another field may or may not, or they might not even use the term. Okay. I deal with that all the time between team science, team research, community-based research. There's all these things. It's like convergence research. Aren't they all the same thing? Well, sort of, but they're born from different fields, and each field or discipline has a tradition and a history and a reason for being, and you have to be sensitive to that. So I just wanted to say those things. I don't want to keep anyone from asking questions. We're actually pretty good on time. Questions or comments for Hannah? Yeah, interprofessional research. Yeah.
I have a comment and a question for Hannah. I'll be very quick. Hannah, great presentation. Again, I learned so much. It was really fantastic. I'll tell you my comment first. When you said you're still struggling to feel like you understand some of the foundational ideas of different fields, I totally felt you. We're in the same place. And I think part of that is because it's based on such a limited review of the literature. I mean, most of us have only looked at 15 or so sources. That how can we feel certain? I mean, even if I looked at 100, I don't think I would feel certain, because you're not in that discipline yourself. And so I think that, for me, what really resonated was when you said, and if we were working on a cross-disciplinary team, because I think that's more realistic, is that we would be having conversations with people and saying, I really don't understand this theory or why you think this is so important. And then they would explain it to us, and we'd probably have a light bulb moment and then go look at the literature and, work it out. But I wanted to, Dr. Ali, did you want to say something?
I just wanted to say, Sarah, that's because you would have had the experience to know enough to ask.
Yeah.
Don't underestimate how important that is in this process. Yeah, right. We hopefully you all will be working on interdisciplinary or multidisciplinary teams. But if you're never trained to ask, you won't ask, because you'll think that you know everything. And that's why some of these disciplinary factors don't mesh, because psychology never thought they could learn anything from genetics, and genetics never thought they could learn anything from therapeutics. But you're being trained differently. You're being trained to know it's more important to know to ask than to know everything.
And I think it's really an exercise in, I don't know if humility is the right word, but if you care, something I've been thinking about a lot lately is, if I really care what people in my discipline think about me, I'm not going to fare well as a translational scientist, because you're bringing in so many ideas that are foreign to people, that are gonna, you're trained in an yes and, or either and kind of way of thinking, but I think a lot of the other disciplines view those as threats. So, and I think it's difficult. But along those lines, my question was really, you did such a great job when you laid out each of the disciplines. I love that you had the parent theories in there. That was super interesting. I think you did such a good job of laying out every single theory that I had a really hard time visualizing if there was like a black sheep, not theory, but if there was like a black sheep discipline. I found in my own work, there are some that they just seem like the black sheep. Like if the disciplines were people and they were sitting around a conference table, which would be the discipline that everybody would be nodding their heads at? And which would be the discipline that everybody would be sort of, I'm not sure about that. And I'm just wondering if you had a perspective on that.
Kind of. I have a complicated approach. I think the bigger issue is that genetics has become so conflated with other constructs. It has been conflated with studies of race, studies of population, studies of families, studies of just like physical differences, that almost every discipline views genetics as important to them, but it's because they've studied something that genetics represents. So if there's a black sheep, it's like people unwilling to say like, yes, I study this thing, but it's not genetics in the way that you're saying it. So I'm not having an ethical issue here or anything like that. So it's more just like not wanting to take onus when there's any kind of ickiness with it. And but wanting to also recognize it because then they're doing genetics. It's just weird, like tossing around the ball of who's responsible when it comes down to like we need to make a decision.
Right.
So yeah, all of them recognize it's important. All of them recognize it's complicated because they've all dealt with it over centuries in different ways. It's just, yeah, it's tied to evolution. Like it's tied up with so many other things that people can relate until they don't want to. And then suddenly it's unique from what they've studied. It's weird. I don't know.
There's trends all over the place where if we really stopped and thought about it, biology is probably a good example. Some people think there's no use for biology anymore unless you pair it with something. Because, you know, I'm not saying I do. What I'm saying is there are some fields that it's like, well, what about biology? Like, what about it? You know, what do you pair it with? I think genetics is becoming so much part of our popular discourse, meaning we know, you know, like all of a sudden viruses are part of our popular discussion, right? Because we're living with viruses, right? And we also know a lot on a very surface level about viruses. We know a lot about genetics on a very surface level. When you said, Sarah, if you went around the table, who would be the black sheep or who would be the, you know, the discipline that everyone nods? I think it probably, the one that everyone nods to would be the one that was most likely to be applicable across disciplines.
That makes sense.
Because there's that ability to translate it to, well, this is what genetics has to do with your metabolism. This is what genetics has to do with longevity. This is what genetics has to do with your eye color. And it makes the bridge. It's usually those models and structures which are so tightly bound, they haven't let any air in. They're like the black holes of the universe. You know, it's like, once you go towards it, you're forever gone. Like we'll never see you again because it's so unrelatable. And I think that's part of the challenge of interdisciplinary work. Doesn't matter if you're trying to do it by yourself or in a group. Ultimately, we need to know enough. We need to have deep knowledge of disciplines. No one's saying we don't. But we also have to understand how those relate to others, especially when we're dealing with particular problems. If we're too siloed, yeah, Hannah, go ahead.
Oh, so I was just going to say this conversation is actually reminding me of why I put those assumptions on my second slide, because genetics for the longest time has not really had its own measurable way of defining it. Again, it's been conflated with other concepts. So I felt it was really important to highlight, I mean genetics in the concept of health. Right. Only that, not genetics selectively, sometimes meaning evolution and all the crap that's like associated with that socially. And so it's very much health. And that is, I think, a lot easier for the disciplines I looked at to agree on something, because the health genetics, that is actually something quantifiable where you can sequence in a gene that you know is associated with disease. There are very like evidence-based ways of determining if it is a health risk or not. So that I think is a little bit more agreeable for people to like agree on, this is what we're talking about. And there's a need, a prompt here. That conversation and whether or not disciplines have this level of like agreeability between them, I think would be very different if I looked at genetics meaning evolution or genetics meaning like race. You know what I mean? Like it depends how you define genetics, because by itself it kind of can be interpreted.
Thanks again, Hannah. We need to move on. I'm sorry.
Okay.
You can exchange on the discussion board. I'm trying to respect everyone's time. It looks like we're going to go a little bit over. We're going to go a little bit over, but we want to make sure that Sarah gets her time. Don't forget, when you post your response, you know, your one-pagers to the discussion board, you can continue having discussions. Okay, Sarah, all yours. Last but not least.
All right, hopefully you guys can all see the slides. Yes? Okay, great. All right, so today I'd like to talk about something that is near and dear to my heart, which is evaluation of complex health interventions, especially in the context of lower and middle lower and middle income countries, as well as screening. So the challenge here that we have is to highlight this specific translational health problem while also outlining the cross-disciplinary research process. And just as a friendly reminder, this is the integrated model of the interdisciplinary research process. We've all seen it, and I won't spend a lot of time talking about it, but I do just sort of want to boil it down to two big components, right? The first is seek to understand the disciplines. So you have to go into it with an open mind. And then the second one is seek to bring them together, to integrate them, not necessarily fully, as Dr. L said, it's a recipe. And so they can maintain their uniqueness, but those are really the two broad components and the two essential aspects of the lens that I'm utilizing here. So in terms of stating the problem, cervical cancer, I won't get into it too much because I know we want to minimize the time spent on the background, but cervical cancer is still a leading cause of death in lower and middle income countries. In Peru, where I grew up, it's the second leading cause of death amongst women. And the WHO has laid out essentially a mandate to eliminate cervical cancer by 2100. And this is going to be incredibly difficult, even with the existence of a vaccine. Screening for cervical cancer is going to continue to be a critical element of elimination. And screening as a clinical process is something that actually really lends itself well to a systems thinking approach. And a lot of people have started to think about it from a sort of a complex health sciences approach. And I want to show you part of the reason for why this is. This is a model that I just put together. It's a really simple onion model, but I think it really illustrates really well the relationships and the different systems of stakeholders that are nested within each other. So obviously the patient is central. You can't screen if you don't have a patient. And they exist within a local healthcare system with healthcare providers that treat them. And both of those groups exist within a community that has its own culture, its beliefs, cultural practices, and then all of those exist within a region and a country that is part of a healthcare system that has healthcare decision makers who every decision that they make trickles down and impacts those community members, healthcare providers, and patients. And then the evaluator can come from within one of those stakeholder groups, or they can be wholly external and just sort of be, totally external to those stakeholder groups. But I think that the reason I'm showing the slides, because I think it illustrates really nicely why you need a complex health systems approach when you look at something like this. So in essence, our problem is that interventions are increasingly designed with a systems thinking approach, but they kind of forget the evaluation part of things. So they design these really complex interventions that really do a great job of taking complexity and stakeholder perspectives into account. And then the evaluation stage comes and they sort of take a much more positivist biomedical approach to things, and they just sort of say, okay, we've done the evaluation. And it doesn't do justice to the screening, or it doesn't do justice to the intervention. And what ends up happening is that decision makers are not convinced. And so things don't change. Treatment algorithms don't change. More women don't get screened. And so it's really tragic, actually, when you think about the fact that people are dying from cervical cancer because we can't design good enough evaluations to be able to show why certain treatment algorithms or why certain decisions should be done differently. So, but we have to start at the beginning, right? I mean, we have to start from finding out what are effective methods for evaluating complex health interventions. So that is the research question, that I started with. It's also the research question for my scoping review, because I'm starting, from level one, where I'm just trying to figure out who's evaluating complex health interventions and how are they doing that? And how can we bring a cross-disciplinary approach into that? And why is it even important to use a cross-disciplinary approach? Well, it really just boils down to this first bullet in green, which is that you have a problem of a really complex nature, and with a multitude of stakeholders that are involved. And if you really want to seek to understand it, and you want to apply multiple perspectives and multiple epistemologies to be able to get really rich information out of your evaluation, then at the end of the day, you're probably going to have to look at it with a cross-disciplinary lens. So just to give you a quick example, if you rely on a purely biomedical approach, then you're probably going to get limited data about what you found. The typical example is a randomized controlled trial. You might find out that certain outcomes work, but then decision makers might still not change their minds about certain things that you find. And that may be because there was something cultural or there were some psychosocial barriers that you didn't take into account there. If you rely on a different approach, for example, taking an anthropological lens or even a business lens looking at change management, that may not be convincing enough to medical providers and public health professionals. And we need their buy-in to be able to make big changes and increase impact. So, this really needs to be everybody playing nicely in the sandbox for us to be able to achieve true change in this area. These were the initial disciplines that I thought could be potentially relevant to the problem. And I look at some of the insights and conflicts in later tables that I'll present. But the ones in green are the ones that the literature showed me are sort of popped up over and over again. And, I think that it's pretty clear, but medicine, I think, is self-explanatory. The anthropology one was interesting to me. And I think what all of this highlights at the end of the day is that things may pop up in your literature review that you would never in a million years have guessed. And so it's always helpful. That was my lesson learned. It's always helpful to do a literature review just for the sake of seeing what you'll be surprised by. Because if you just put a team together without doing an initial lit review, you may be missing a valuable member of your team. And this is just sort of general sample from the literature review, just so you can see all the different journals. Those are highlighted in yellow. Things that I was particularly surprised by: the System Dynamics Review, the International Journal of Cancer, highly like biomedical approach. A lot of variety. I was really pleasantly surprised by the variety that I saw. These are the databases that I consulted. I included Google Scholar for gray literature because I think when you're looking at evaluations, a lot of organizations, like one of my primary clients, the Lupus Foundation of America, are not motivated always to publish. They're working on such a rapid pace that they don't think to always publish, but they might present at stakeholder meetings or big conferences because it's good for them in terms of visibility. And so I thought that would be just an interesting addition. The others I think are pretty self-explanatory, but let me know if you have questions at a later stage. And then this is the template that I use just for gathering data. No rocket science here. This is also the template that I'm using for the complexity course as well. So in terms of the challenges that I encountered when I consulted with disciplines that were not my own, couple different challenges. So complex health intervention actually had a different meaning clinically than it does in terms of program evaluation. So I had to read those articles a couple different times to really understand what they were referring to. What they really mean when they say complex health intervention is an intervention for a health condition that's very complex. Whereas what I was really thinking about was a intervention that is complex and that it has multiple elements and multiple layers of stakeholders and a certain inherent level of unpredictability. I also, sort of like everybody have different comfort levels with, some of the epistemologies that were used. So for me, it was a little bit easier to read, or more interesting, I should say, to read some of the things in anthropology than it was to read some of the medical texts that had a little bit more sophisticated language. I also thought it was hard for me to look at some of the stuff in public health because it is so blended. It takes from a lot of different disciplines. And so what I realized was if I was doing this again, I'd probably pick something within public health and use that as a discipline as opposed to using the entire discipline. There were new databases for me to navigate. That was a challenge. that I didn't expect, but not everything is like PubMed. And I just felt a little bit of discomfort around my general lack of knowledge about reputable journals and standard assumptions about perspectives in other fields. So I think, you know, when you're sort of imbued in a certain field, just through conversation with your colleagues over the years, you get to know what is the reputable journal, what are the standard assumptions. But when you're looking at new pieces of literature, and with so few or such a limited literature review that we've done, it's really hard to look at an article and say, is this something that I can really trust? Or did I just come upon this article because it had the right keywords, you know? So that, I think building trust it's really building adequacy, which leads to building trust. But I think that for me, that was a big piece, was that lack of adequacy went hand in hand with a general lack of trust. In terms of where the literature may need to go from, the literature search may need to go from here, I think the main take home for me was that this process is so iterative that it's necessary to continue to evaluate over and over again potentially relevant versus most relevant disciplines. And you might end up bringing, you know, disciplines that you had discarded back into the fray. And it may not be because they appear over and over in your lit review. It just may be because they have a really interesting perspective that you want to bring into the conversation. And then I think for me, you know, a big step that I would focus on going forward is to identify those major theories. I didn't go through the process of the parent theories, and I think that's really key. And moving forward would do that for sure. In terms of key reflection points on how I've grown in my adequacy skills and what I still need to understand, for me, I think what was really there were two take homes that for me were really critical. The first was the importance of starting with a preliminary or broad literature review and helping that literature review inform your perspective on things, as opposed to coming to it with some predetermined ideas about what I mean, that's valuable to come with predetermined ideas, but I found that doing that preliminary literature research really challenged a lot of those preliminary ideas that I had. And then in terms of what important information to gather to develop adequacy in each discipline, I found it really helpful to sort of look through the list that Repco and SOSTAC had. And I thought that there were three really key aspects of this list that really jumped out for me that I think I should be thinking about anytime I look at a different discipline. And that was disciplinary perspective, methods, and bias. But all, you know, on the whole, all of these for me were really interesting. And I almost want to take a checklist when I'm doing cross-disciplinary research, or even frankly, like facilitating a conference or a conversation, you know, where you sort of say, have we really looked at the particular disciplinary perspective that we're taking? What are the assumptions? You know, why are we choosing these methods, and what are the biases that are inherent in this? So for me, that was those were the most helpful things. And in terms of analyzing my problem from the perspective of each of the disciplines, I thought they each brought something to the table, some more than others, but it was helpful to see all of them. I don't know if we have time for me to run through them all, so I think what I'll do is probably just pick a couple that I found really interesting, and you know, certainly ask me questions when I'm, you know, done with the presentation if you'd like to learn more. For medicine, I think there was a lot of really good biological insight on HPV screening and treatment screening algorithms and treatment algorithms, and you know, once you've screened somebody, what do you do with them? But it was pretty straightforward, and I think, you know, on the whole, the insight that they contributed was really, you know, clinically, how do we manage this problem? So if you had focused on medicine alone, you would not have had a very complex evaluation at all. I liked in my case, what I saw from psychology was sort of more on the squishier side, where they talk about insights on psychosocial barriers and facilitators. That's a big part of why people seek screening or don't seek screening. And so I think from my perspective, that was a really important addition as well. Anthropology was, for me, was the black sheep at the conference table, because it was, nobody else talked about ethnographic research. And yet I felt like they're bringing something really interesting to the table, and the idea of embedding yourself into what it is that you're studying, and really trying to understand it from the inside. I think as opposed to just sort of what we would do in public health, right, where we just do our in-depth interview and then walk away and we go, well, we've got our data. So I think that was really an interesting insight as well, was sort of the value of ethnographic research and the impact that culture can have on these. I'll move forward because I know we're short on time. Oh, and health informatics. Health informatics, the insight they really provide is, how do we improve patient care through integration of technology and communication about patient care? And this could be so helpful and could do so much when you're looking at an evaluation of screening practices. But unfortunately, in LMICs, it's not quite as applicable. And so I thought it was really interesting, but ultimately not as applicable as I wanted it to be. So in terms of identifying conflicts between insights and envisioning common ground and coming towards a new, more comprehensive understanding, I think in terms of conflicts, it's pretty predictable. For the most part, accepted evaluation methods for the biological sciences and the social sciences varied broadly. The medical and lab sciences and some of the public health data was much more on the let's do an RCT side, and then others, I think, like anthropology or psychology, in my case, we're looking at things much more from phenomenology aligned perspective. Some of the disciplines don't lend themselves very well to working in LMICs, so there's good data. And just to clarify, I think I've said this before, but LMIC is lower and middle income countries. So it's not that the disciplines themselves don't lend themselves as well to working in these, but that the insights provided by those disciplines didn't lend themselves as well. And then there are varying definitions of what complex health interventions entail as well. So that was a little bit hard to tease apart. For envisioning common ground between these conflicts, I found mixed method studies to be really helpful to integrate different recommendations. So for example, the idea that we don't really need to be either or, we can do mixed methods research and we can integrate a variety of different types of methods, whether be it quantitative or qualitative. Some concepts, though, I do think would be prioritized more than others. So the idea of pragmatic person-centered care might be prioritized more than something like technology as an evaluation solution. And then I think also another way for us to envision common ground between these conflicts is to identify concepts with different meaning and then create clarity around these. So as I mentioned before, what is a complex health intervention? If our cross-disciplinary team is sitting around the table, that's probably the first thing that we're all going to need to arrive at clarity around, is what do you mean when you say complex health intervention? And let's all agree on what this entails. And then ultimately, I think it's important in this particular case to take a problem-solving approach. So at the end of the day, there are conflicts between insights. There are different assumptions, different ontologies, different epistemologies, but ultimately the goal is to create and evaluate programs that help more women get screened so fewer of them die from cervical cancer. So I think we need to keep that in the background when we're talking about these things, because ultimately we can spend a lot of time talking about some of the conflicts between these different disciplines, but it just may not be useful in the time that we would have potentially with this cross-disciplinary team. And then finally, I think in order to achieve a more comprehensive understanding, what I would do is get everybody together in a room and map out each discipline's perceived evaluation methods and really create a broad vision around the context in which each of these would be implemented, and the feasibility and acceptability of these methods alone and in conjunction with each other. And then tie it back, as I mentioned before, to ultimately, how are you making an impact and how are you creating and evaluating better programs for women to get screened, right? So I think in terms of how I might be required to communicate my understanding of the new insights, I think for me, focusing more on visually mapping things out would be very helpful. Facilitating conversations that take a problem-solving approach would be very helpful as well. And then developing a new integrated model or framework based on some of the other models that we come up with as a team as well. So some of the sources of conflict that I looked at were when I looked at the accepted evaluation methods for the biological sciences and social sciences and how broadly they varied. It really boiled down to assumptions about epistemologies. I don't think that this is going to be anything new to this group, and we've talked about this already. For health informatics and communications, presented solutions that didn't address the specific resource challenges associated with working in the LMICs. And I think some of that might be related to ontological assumptions about the world that each discipline exists within. So some disciplines some disciplines just are more prevalent or less prevalent in LMICs and do less work in LMICs. And so naturally there's less published about those disciplines in those areas. And then again, going back to what I found before, just varying definitions on what complex health intervention entails. So the same concept masks different meanings. I think that there were three main audiences I could think of that would be interested in this research so far. I would be most interested in getting this research in front of policymakers because I think if we can evaluate new screening programs in a way that is motivating and incentivizing for them, then the way that screening procedures are currently done could potentially change. I also think it would be obviously interesting for researchers like myself who are looking to evaluate complex interventions and who want to understand what's the best way to do that. And then I think patient advocacy groups as well. Patient advocacy groups who are working currently with different community groups on cervical cancer screening, who want to create good interventions and who want to create accompanying evaluations for those interventions to show that they're making a difference and that possibly current screening practices should or shouldn't change depending on where, what the screening practice is for each location. So these are, the 6 core ideas about creating common ground. And I think there were just a couple take homes or, ideas that this sparked for me. Some of the main things was really the idea of building bridges and not walls, keeping an open mind when you're working across disciplines. I thought it was really interesting that we are already primed to think in a cross-disciplinary way. And yet all of our education tells us that we're not. So I think sort of fighting to overcome those, what we've been taught and sort of realizing that we're actually much more naturally inclined to work this way than we think that we are. Oh, and sorry, one more thing. And number 6 is really interesting, requires using intuition, which is sort of this process of, mental gestation where you have understandings in sudden leaps and bounds. I think that's really important when you're working across disciplines, because in my experience, there are moments or several meetings or several phone calls where you just don't make progress. You just don't make progress. You just don't make progress. And that's when I think you're at risk of throwing in the towel. And I think, you know, in this case, it would be important to just acknowledge that we need to give things time and let things percolate, not for too long, but for enough time for us to really be sure that we're all giving this the time to be able to move forward. So as far as finding common ground, you know, we talked about some of the conflicts, and in blue, I've really just listed what the conflicts boil down to, so you don't have to read the whole description again. So we've got these three conflicts, which really boil down to assumptions about epistemologies, ontological assumptions about the world that each discipline exists within, and then the same concept masks different meanings. And then finding common ground are some of the techniques that I would use to be able to find common ground across disciplines. So for the first one, where there are assumptions about epistemologies that conflict with each other, I would use transformation techniques in this area and say, as opposed to having either a qualitative or a quantitative approach or a qualitative or quantitative lens, let's use the concept of triangulation to show that both of these can be helpful, and think about how we want to use mixed methods to be able to find common ground between these disciplines. For the ontological assumptions about the world that each discipline exists within, I was thinking that using extension techniques could be really helpful, because what we could do is just extend the ontological assumptions about screening evaluation settings from public health and LMICs into health informatics, molecular science, and communications. So in other words, just to put that in plain English, just because their research didn't take place in LMICs, and just because the researchers weren't thinking about LMICs when they wrote those papers or presented those concepts, it doesn't mean that it's not useful to us. So we just need to say, let's take what you've done and extend it into the world of, you know, global health. And just, if I had that researcher in front of me, I'd say, just for the sake of argument, let's assume that you're in Peru with me. How does this modify what you're working on? Or how does this, you know, change, if at all, your perspectives? What can we use? What is still useful to us about what you're bringing to the table? And then in terms of the same concept masking different meanings, I would use redefinition techniques. So as I had said before, just really examining all the definitions and finding common ground, ultimately arriving at a shared definition of what systems thinking entails in this context. So it wasn't just that the medical field used complex health interventions in one way and public health used it in a different way. It was also that within complex health interventions, there was systems thinking, and then there was complex health interventions, and then there was complexity lens. And there were all these different ways of describing things that where I wasn't 100% certain that they were talking about the same things, because it's all part of a very brief background section. That's not the point of the paper. And so that's an area I would have liked to dive into a little bit more and just make sure that we're all on the same table when we talk about doing that.
Could I cut in, Sarah? I'm just worried about the time. We're about 10 after now. Do you have much more to?
No.
Okay, go ahead.
I can be very quick.
Sure.
Okay. This slide, I don't think I have to really go through this slide because I've already talked a lot about taking a together and versus an either or approach. And that's really what this slide boils down to. And then in terms of next steps, as I mentioned before, I would just model the research problem with a physical team. I imagine each representative at the table. I would definitely want them to look this over with me and comment on the different stakeholders. And then I also would like to expose them. What I would like to do is take a model, which is very common in implementation science, which is the re-aim model, which tends to be a little bit on the positivist side of things, and it tends to be very outcomes focused. And even within the outcomes, there are certain outcomes that are accepted and certain outcomes that are not. and just apply a cross-disciplinary lens to it. So the stuff that you see on the outside are really questions and prompts that I would use to facilitate a discussion around how do we expand the re-aim model and challenge people to use a different way of thinking about things that involves lots of different disciplines as well as their perspectives and assumptions. And I think that's it for me. Yep.
Great, very nice. Thank you very much. You made me think of a couple things I want to get out there for everybody. One is you're going into the direction now of how would we manage a team around this, and you've said a couple times in your presentation, I'd like to get all the people around the table. I'm not sure that's as metaphorical as it might sound. It might be actually real. Let's get all the people around. That in your third assignment for this course is thinking about what do we have to do to make sure that we have a plan about bringing people together that represent these different disciplines and manage, in effect, how they're going to relate to each other, how they're going to communicate. The other comment I wanted to make goes back to way into, I think, session 1, where we talked about the difference between multidisciplinary, interdisciplinary, and transdisciplinary. And you said a couple things that made me think back. Let's remember that disciplines on their own that just sort of live out there is a multidisciplinary arrangement. They just, they're all separate. And if we need to learn, if we need something from genetics, we grab it. If we need something from interdisciplinary, is this idea that the disciplines affect each other's way of doing business. Okay. There are fields that are interdisciplines already. Like public policy is already an interdiscipline. It's made those connections, and as a body of inquiry, it is interdisciplinary. It takes into consideration society, policy, economics, business, etc. That is, team science is an interdiscipline. It looks to management, leadership, psychology, anthropology, etc., etc. You said one thing about those moments when things just sort of happen, like they're few and far between possibly. Julie Thompson Klein, who is a good friend of mine, but also like the international, guru on transdisciplinarity. She says the idea of transdisciplinarity, where you come across something that's so unique and so integrated that it's a new thing altogether. Like nanotechnology is like a totally new thing. It's not just two fields coming together. It's like totally new. We have other things like that we come across, and it's like we're just blowing away the way we're looking at something because it's so much integration. She always says those things come in fits and starts. So to your point about, not giving up, perseverance is an important part of this, because it's not easy to do what is being suggested here. And sometimes the light bulbs won't go off for a while, or they go off so infrequently, you wonder, is this even worth it? But you said a couple of things that I just wanted to make those comments because I think they're important to, I think, the way that you've explained the work you've been doing. But I want to make sure everyone gets a chance to say something if they want to say something. So please do. I know we're a little over time, but Sarah, appreciate your feedback very much, I'm sure. So if you have anything you want to add or question.
Hi, Sarah. Great presentation. I had a question about, in my work, I do program design and evaluation, and I work with investigators, and a lot of times the evaluation piece is an afterthought. They're like, oh crap, we have to evaluate what we're doing.
Right.
Did you find any of this in the literature? Like, oh, we're doing this intervention, we're designing it, but in terms of actually evaluating, there have been a better forethought in terms of what it would look like?
Yeah, so I think that's actually, it's rare that you have an intervention that is, you're supposed to design your evaluation as you're designing your intervention, as you know, but it's rare that it gets fully thought out because I think a lot of people are just busy with grants and funding and, you know, all of that stuff. So what I saw in the literature was that people do design their evaluations in tandem with their interventions, but they're seldom as well structured as the intervention itself is. Or, and this is what I saw more of, there are certain standby evaluations that I'm speaking really more from a public health and specifically an implementation science perspective. There are certain frameworks and models of evaluation that have been used for a long time now, like RE-AIM is a really good example. Everybody knows RE-AIM, everybody uses RE-AIM. But the problem, and RE-AIM is fantastic, I love RE-AIM, but the problem is when you don't question it or think about it enough and you just sort of apply it and you say these 5 components of RE-AIM are, you know, I don't have to think about them because it's been thought out for me. And I think, or question it, you know, because what I was excited about when I was creating this expanded model for the RE-AIM program was that it was sort of pushing back on RE-AIM a little bit, which where I come from, you know, is not okay. but did that answer your question or?
Yeah. No, it was really helpful to see. Also, I feel like
in the literature
with the RE-AIM framework, sometimes I feel like investigators don't really know how to truly evaluate. They're more looking at like the statistical outcomes, like what, but the implementation piece of it, I feel like gets a little bit lost. And that's just mine.
Well, it has its own assumptions and it has its own epistemology as a framework. I mean, you can't get away from that. Everything does. But the question's going to be, is it drawing you to insights into what you really want to know, like process, for instance, or is it outcome related? You know, what do you want to use it for? And I think this is a good example where something that's seemingly process oriented is highly affected by an outcome orientation, right?
And I actually thank you for bringing that up because I wanted to ask Sarah about this when you were doing your search, whether things were dissected down to process eval versus outcome eval. When I think of RE-AIM, and I come from more like the public health side, we can't, and maybe it's a CPPR work or something, but we can't think of RE-AIM without considering process eval before actually looking at the outcome part. So I wonder if it's because these other disciplines aren't like that, right? So that was really interesting to me because for me, it was like, it's natural, right? It's obvious, but you know, from your presentation, it reminded me that it is not. And another thing, like obviously this is my area and passion, so it was really applicable. But I challenge you to kind of also think about disciplines like law versus policy, because you know, like, so whereas policy is what are we gonna do, law impacts and especially women's health, right? Laws are like those set standards that we must abide by. So how does that affect something like cervical cancer screening and what is available to the country that you're working or the village or community? So that was another thing. And then health informatics, again, in that area of combining technology and all of this, my area. And so I think of biomedical and the engineering field, which is now coming together to create technology that, you know, when people think of technology, they think of maybe something new or very, very innovative like nanotechnology. But when we combine with them, we're using new technology, like let's say machine learning and AI concepts, but applying it to stuff like text messaging still, right? So text messaging, I'm not saying all countries and villages also either have that, but some do. And I think Peru, one of their cervical cancer program is moving towards that and applying, you know, uniquely the newer concepts in technology and biomedical engineering to that, something that is already kind of accepted is another way to combine the various disciplines too. So, you know, great topic, great way of thinking about everything. So
very helpful. Thank you so much for your suggestions.
Thank you,
I don't want to cut anyone off, but is anyone else, Apple, did you have a question or Hannah?
Yeah,
Anyone?
I was just curious on how you were really looking at the perspective of the countries and the technology that's available. I think Dr. Lei has talked about that. As somebody who did my undergrad in the Philippines and studied occupational therapy, which a very Western, has its own Western roots, I didn't really understand occupational therapy. Well, I was like, this doesn't make sense until I came here. And so, thinking from that perspective and how medicine is practiced in those areas is so different from medicine here.
Yeah.
They may have a lot of time talking about interviewing the patient because we're not based on fee for service of like go, but also on the other perspective, the more affluent families may get more of these diagnostics, where that's the poorer families may not get the diagnostics, and all they only go to their community health centers, which is more of which should have a prevention approach. But all these modern technology stuff is also very, very difficult for people to really grasp. So I mean, just Dr. Lei is talking about, I think Takeda is also doing a lot of diabetes work through text messaging, using or even Facebook as a platform, because of the absence of smartphones. Usually these families get hand-me-downs for more, donation, or these. And so looking at that, like even that text messaging bots that are used for screening could be something that you could also consider, but very low tech, especially in low and middle income countries, because high tech doesn't work. There's no infrastructure, there's no money. And plus also you have to bridge the gap too of the education, because we may be so, like in the Philippines, when I go there and I say, oh my goodness, this is how things are done, I just like, I'm appalled. But something to think about if you want to address low and middle income countries.
Yeah, that's really interesting. And I actually think, Apple, that you and Dr. Lei have also exposed a bias. So I have an opportunity to develop my adequacy a little bit here, because you're right, there is a huge range of technology that's available across LMICs. And I think that my bias stems from the fact that I was really thinking, the reason why I'm doing this research is because ultimately I want to use it to evaluate a program that's in Iquitos. And Iquitos is landlocked in the middle of the Amazon in Peru. The women who are getting screened don't even have like non-smartphones, let alone smartphones. So I think I was very biased because I was thinking about, well, I want to use this for me later when I'm writing my dissertation, as opposed to thinking about it a little bit more broadly. So thank you for pointing that out. That was really helpful.
And also perceptions of cervical cancer, things about promiscuity and all that stuff too.
Yeah, stigma's huge. I saw your comment about, how does healthcare, what the intersection of healthcare system and culture. And I think that's so huge, psychosocial stuff, stigma, all of that plays in such a big way. I think for us in Peru right now, that's being done. A lot of that is being done right now, and has been done for a little while. But where we're encountering a lot of resistance right now is with the healthcare system and the healthcare providers and people who are up high in the national, setting national priorities. And so I think that's really, because part of it is, if you change a screening algorithm, or like you use primary care professionals to do the screening, that takes money away from the specialists. Yep. And so, there's a built-in incentive right there not to change the law. And so part of the reason, for really having a complex or a systems thinking intervention and then using that lens to do an evaluation is so you can really conclusively show you need to change the way that you're doing medicine right now, because you're not benefiting the women who should be getting the health care that they need.
Yeah, Sarah, I think there's
okay. We're really over time now, and I think we're off the topic of cross-disciplinary design and talking about the health problem per se. So I want to leave this conversation to you guys offline, and ask if anyone has any questions about this weekend. I want to get that in. I sent you a bunch of things today. I'm not sure you got to see them all, with the schedule and so forth, and also our guest speakers and so forth. the luxury of going first is that you have less to do for the rest of the week. So good job to everybody. Don't forget to do your feedback forms and post them to the discussion board. I'm sorry, I forgot to mention this. I did record our session so that others from other groups, if they want to hear your presentation, they could, unless anyone has a major problem with that. I'll be posting that so others can, if they want to, take a look at the presentations. I just, when are the feedback forms due? I would say if you could get them in by the end of the week, it's fine. You know,
Sorry, could you clarify, is it feedback form and then we have a round of revising slides from the feedback and then post the slides again? I couldn't quite understand what we're turning in and what.
Yeah, well, if you want to revise your slides from feedback, that's fine. We're not going to be checking each feedback form against your slides to see if you made every change. I mean, if you heard something that you want to incorporate or you want to change or whatever, feel free to do that.
Okay.
Okay. We're not going to sit there and surgically check against, all the feedback forms. It's really more to give the presenter an opportunity to get your thoughts on what they have done. Okay.
And do you want a physical copy of the slides? I think I've already emailed mine, but just for the others.
Yes, you want to post them into the gradebook.
Okay.
So assignment 1, you post into the gradebook. Yeah, that's right.
Okay, that sounds good.
Okay. Yeah.
Great.
Great job. Good job, everyone. Thank you very much. I learned a lot. And I hope we all learned a little something about how Repco and Stotec can help you as you look forward into this work. I'm looking forward to seeing you all again on Saturday. Saturday is you don't have really many big deliverables on Saturday. It's a lot of listening and reflecting on what we've been doing. So I look forward to seeing you all again. Stay safe, as they say. Vote early, vote often. If you haven't voted yet, tomorrow's your day. And be safe regardless.
I just pressed my ballot.
Night.
Yay, all right. Be safe no matter what happens. Be safe. You're all in different places and who knows what's going to happen. Okay, so just be safe. We're keeping tabs on you all, okay? And Daisy, continue to have safe travels. Daisy's traveling at the moment. Okay. Thank you all. Have a terrific night. What's left of it?
Bye, everyone.
Okay. Bye-bye.
Bye.